Okay. Good morning. This is Laura Rudensky, the chair of the board for Westside Interagency Council. Thank you to everyone joining us today for our first online WYSIACA meeting. We will be continuing in May with another online meeting, and we'll update all of you as we move forward. I'm hoping everyone is safe and managing through this challenging time. But I just wanted to give a few brief announcements before we begin. Thank you to so much to those of you who have paid your membership dues, as we have gotten further payments. Please remember the annual membership dues are $75 for agency membership, $50 for individuals, and $20 for students. Your dues are essential for us, and you can go to the website www.wysiaca.org and use the PayPal option to pay. So welcome. Our program today is New York State budget changes on Medicaid. Valerie Bogart is presenting. She's been the director of the Evelyn Frank Legal Resources Program since 2002 and has been a tireless advocate and amazing source of information on behalf of older adults. In 2013, the Evelyn Frank program moved to the New York Legal Assistance Group, where Valerie continues to serve as director of the program. You should have received an email with PowerPoint and information, and during this webinar, you'll be seeing that info as well. Next month, on May 21st, we will be having an online meeting entitled Aging in Place, Neighborhood Communities, and we will be having 3 different speakers, one from PSS Dementia Friendly Community Program, which is a very interesting program, as well as 2 other groups, Bloomingdale Aging in Place, as well as the group Life Force in Later Years. These programs provide volunteers and other resources to older adults living in the northern neighborhoods of the Upper West Side. So please join us to learn about them, as well as the Dementia Friendly Community Program, which has been providing services at Morningside North. Stay tuned for more information about our June event. And now I'm going to turn this over to Valerie so that we can learn more about Medicaid.
Okay. I assume everybody can hear me. Thank you, Laura. And thanks to the Westside Interagency Council on Aging for inviting me to do, we usually do an annual, I usually come to a meeting around this time every year and talk about any changes that might be happening. And when they invited me a few months ago, who knew, actually you invited me like probably a long time ago. And I thought, well, maybe the budget would be settled by then and we'll have some news. But little did I know that we'd be in the middle of a pandemic and that there would be major, major changes in the budget. So before we start, I'm going to invite Haley Rhine, who is the Avodah Fellow and Paralegal Advocate with Evelyn Frank Program, just to give a few logistical information for the webinar.
Great, thank you, Val. Good morning, everyone. I hope you're all staying safe and healthy at this really challenging time. I'd be happy to help anyone with any technical difficulties throughout this webinar. Please feel free to chat me directly. I'd also like to go over questions, as we like to save questions for designated periods of time. So please go ahead and use the chat function. When you select where to send your message, please select to send question to staff. That will send it to me directly. And when the time comes, I'll announce and go through the questions. So if anyone has any questions about tech, please feel free to message me directly, as either the organizers, presenters, or directly to me. And for questions, please choose the send question to staff option for the chat function, and it'll send it up to questions. Thank you.
Great, thanks, Haley. And also, if you didn't get the handouts, I tried to send them out, but some people registered late. And there's this side, go to webinar bar. There's a little thing for handouts, and they're both posted there. So you could also download them there. Okay. All right, so we're going to start, and we're going to spend most of this presentation on changes that were enacted in the state budget. Hopefully we'll have time, just 5 or 10 minutes at the end, to talk about some of the changes in effect now because of COVID. There's flexibilities, and of course, the way Medicaid is run had to be sort of turned upside down because everyone who administers Medicaid is also affected by this crisis. And there are some flexibilities that we want to make sure everyone knows about. Great. So, let's see. Okay, so a little plug for my organization, the New York Legal Assistance Group. And we now have a COVID hotline, which maybe by the end, Haley, you could look that up so we could announce it. And we have lots of information about COVID-related information on our main website, NYLAG.org, and also on nyhealthaccess.org. So the game plan is to talk first about the financial Medicaid issues in the budget, which is really the new Lookback and transfer penalty for home care. Then changes on Medicaid home care eligibility and assessments, and then wrapping up with some overview of some of the COVID adaptations. So we're starting with a review of what the Medicaid redesign team was and the new Lookback. If you're a lawyer, you're interested in seeing the actual budget law, if there's a hyperlink right there to the something like 500-page budget law, and beginning at page 259 is section MM, where the Medicaid changes are that affect consumers. Now, naturally, in a 500-page budget law, there are lots of other changes. There's lots of changes for providers and reimbursement. We're not talking about a lot of that. I needed to pick the main issues affecting consumers. So you may have heard, got a lot of press, that Governor Cuomo appointed a Medicaid redesign team, or MRT, to recommend savings of about $2.5 billion in state dollars, which means about $5 billion in total expenditures. And that was before the pandemic, because the governor had viewed Medicaid as spending too much over something called the global cap, which is a sort of an artificial cap that was enacted back when the governor first came into office. And the MRT got a lot of criticism from consumer groups and others, and it's mainly made up of industry insiders, people in the hospital industry and insurance industry, and not consumer representative. So during the course of the budget, of course, the pandemic arose, during the 3 months in which the budget's usually renegotiated, and that just increased the fiscal pressure to make cuts in Medicaid. So the MRT came out recommendations. The budget deadline every year is April 1st, and the MRT's recommendations were made within a week before that deadline. So there was really no time for the legislature to negotiate on which of the recommendations to adopt. It was sort of a take it or leave it situation. And 2.2 billion, sorry, typo there, that's billion, not million, in Medicaid cuts were enacted, and about a third of those affect long-term care services in the community, either eligibility or actual delivery of services. So a lot of people on this call, work with people who are older and people with disabilities who depend on home care. So that was a big, big target of these cuts. Now, be aware that it's not over. The budget includes new powers for the state budget director. I'm not sure what that noise is. Haley, do you hear that noise? Okay, I don't know. All right, it stopped. Gave the budget director new powers to make further cuts if revenue from taxes for the state is below anticipated levels. And those cuts can be made at the end of April, I think at the end of July, and at the end of December in 2020. Now, gee, I wonder if tax revenues will be down this year. You know, that's not even in question, right? Because of the economic fallout of COVID. So we have to expect that there could be further cuts besides these that the legislature basically gave just full authority to the governor's office to make, which is very alarming. So at the same time, we have on the federal level, they're just about to negotiate the fourth stimulus bill, right? And one of the things from the stimulus packages gives extra money, federal money for Medicaid in the state, called the federal financial participation, the state's share. And it increases the state's share by, I believe, is it 6.2%. So usually during the pandemic, usually the federal government pays 50% of the cost of Medicaid services in New York. So now it would be like 56.2%, which is worth as much as $6.2 billion for New York. But there's a string on that, and that money is only available to a state that maintains eligibility standards, methodologies, and procedures that are no more restrictive than what existed at the beginning of 2020. So this is called the maintenance of effort requirement. Sometimes we refer to it as MOE. And you may have heard during the governor's daily presentation on COVID while the budget was being negotiated that he was angry about some technicalities in the federal law that would deny New York State these extra Medicaid funds. Well, this is what he was talking about, this little technicality that bans a state from cutting eligibility for Medicaid during a pandemic. So we salute Senator Schumer and New York's congressional delegation for standing firm and making sure that the maintenance of effort was enacted and so far in the stimulus package. But you can see the red alert on this slide is that the governor is still pushing to end the maintenance of effort requirement in later stimulus bills that get negotiated. All right, so somebody's not on mute somehow. I don't know how that is. So the way that the governor got around this is that they did make cuts in the budget. They did cut eligibility. They did change methodologies, but they made the changes effective October 1st of this year and gave the state budget director authority to delay implementation up to 3 months after the state emergency is declared over. So that could be, that's like the end of January of 2021. So they enacted that delayed effective date, hoping that that would be enough for New York to still get the $6.2 billion in federal Medicaid funds, but still cut eligibility. Now, there might be some legal questions there. The fact that they enacted this, does that violate the maintenance of effort requirement? And that's beyond what I can talk about now. I don't know. But there's certainly some gray areas there. So first, There is some good news from the budget. The MRT had proposed to abolish spousal refusal. And this would have been the 29th time this was proposed to be eliminated in New York State. But it was not eliminated. There is still spousal refusal in Medicaid. And for children with chronic illness, sometimes their parents use parental refusal. It's the same thing because it's the refusal or lack of ability of a legally responsible relative to provide income or resources towards the medical costs. That's what spousal refusal is. So there were some rumors that that did go into effect. It did not. It remains the same as it always was. Another proposal by the MRT was to reduce the spousal impoverishment resource allowance, technically called the CSRA, that the spouse of a member of an MLTC plan or a nursing home resident or someone in one of the waiver programs like the TBI waiver, they wanted to reduce that to the minimum allowed by the federal law, which is only $25,000. New York's level is at $75,000, and it's a little complicated, or half the couple's resources up to about, I think it's about 100, in the range of 140,000. So New York has always had in the middle there, about 74,000 and change, because they never enacted a cost of living increase in that, so it's just stayed flat at the 75,000. So if anything, advocates think that should be increased because of the increased cost of living. But since it was enacted over 20 years ago, but it didn't change, and at least it wasn't lowered. So that's good news. There's also something called prescriber prevails. This doesn't affect our clients who receive Medicare because they get their prescription drugs through Part D, but those who are not on Medicare depend on Medicaid for their prescriptions. And this is an important right to make sure they get prescriptions if there's a drug that requires a prior approval, that their physician statement of medical necessity should be enough for them to be able to get the prescription filled. And that was also survived. But that's it. The rest of it is pretty much downhill. I want to give a big disclaimer here. This law is new, as most laws are. It's very sketchy. It's just bare bones. A lot of the details on policies will need to be filled in by the State Department of Health, whether through regulations, directives, or something. Some of it might get fleshed out in fair hearings or litigation. So how it's going to be implemented is I'm giving you my best guess of how it will be and how it should be implemented, but these are really my views. So have that as a caveat here. So the look back. This is probably the biggest change in eligibility that's been done in I don't know, in my career. So some background on the look back. We want to make sure everybody's on this level playing field. So federal law requires a look back for nursing home care to be paid for by Medicaid. So if you apply for Medicaid for nursing home care, you must document all financial records, the applicant and the spouse, during the 5 years before the application. So that 5 years is called the look back period. So why do they do a look back? The local district, which in New York City is HRA, combs through those 5 years of records and looks for any large withdrawals, checks that could be considered a transfer of an asset. And it's a big job because some big checks could just be for rent, right? So they have to say, okay, that's not a transfer of an asset because it's for fair market value. So they're looking for things that are not for fair market value, which are essentially gifts to family or things by law that are considered gifts, like paying for a grandchild's education. Can be a gift. Sometimes it's not considered a gift because of the circumstances. We'll talk about some of the exceptions. So if something is considered a transfer and they look at whether there are exemptions, which we'll review briefly, then there's a transfer penalty. And that penalty changes every year, but this year in New York City, for every $12,844 transferred, Medicaid will not pay for 1 month of nursing home care. And that penalty is different around the state. You can click on that footnote to see what it is in your area if you're not in New York City. So what's changed? Federal law says states may require a look back for Medicaid home care services. And New York State never took up that option until now. So what did they enact? If you're applying for Medicaid for home care or another community-based long-term care service, there will be a look back, but they made it less than 5 years. It's going to be a 30-month look back, 2.5 years. But it will work like it does in the nursing home. HRA and the other local Medicaid agencies will have to ramp up staff because this is a big job, and they'll be combing through those bank records to see if there were non-exempt transfers made in those 30 months before application, and if so, a penalty will be applied, and the person will not be eligible for community-based long-term care for the penalty period. Now, here's a note on this, which could be confusing. The Medicaid application must include the 30 months of financial records for the applicant and their spouse, because even though the person might be using spousal refusal, they must still document the spouse's assets during the look-back period. So the spousal refusal would mean, okay, the spouse has $50,000 and they're refusing to make them available. Fine. And those can't be considered an eligibility. But did that spouse transfer another $100,000 during the 30-month look-back period? Because if so, that transfer applies to the applicant and would impose a penalty. So I think now when people use a spousal refusal, they sometimes think that they don't have to submit proof of the spouse's income or assets. And as a practical matter, they don't, because if there's no look back, it really doesn't matter what their income or assets are. I mean, it matters to HRA whether they're going to refer the case to their legal department for possible support claim, which everyone who files a spousal refusal has to be prepared for and be counseled about that could happen. So we usually, our clients have moderate assets and income, so we usually encourage people to disclose everything, because the refused amount of money is so low that HRA will not pursue it. So we'd rather make that clear right away, and the client won't have that hanging over their head, that they'll be their spouse will be pursued for support. But now I think it's going to be mandatory. It's not, so you have to start getting your arms around that, because that's a big change. So what are the community-based long-term care services that the Lookback will apply to? So the first 4 bullets are lined out in the law. The statute says personal care, home health care, private duty nursing, and assisted living programs. It doesn't specifically say CDPAP, Consumer Directed Personal Assistance Program, but I'm pretty sure that they would lump that into personal care. And it does say that DOH may designate other services by regulation. So they're sure to include CDPAP. It doesn't specifically say MLTC, but MLTC isn't a service. It's a delivery model. So my guess is that one will be ineligible for MLTC, the Medicaid Advantage Plus program, PACE, and possibly the waivers. We just don't know yet how the state will define it. Will they include the nursing home transition waiver, the traumatic brain injury waiver, people in OPWDD? We don't know, but because it's going to be up to DOH to designate, which means there's some room there for some advocacy maybe to exclude people in some of these programs. So when does this change take effect? As I said before, it can't take effect before October 1st because the law is delaying it for the reasons I said before, so they get that $6 billion in federal funds. So the soonest it can apply is to applications for Medicaid after that date for when the person is seeking community-based long-term care. This does not apply to people who are just applying for Medicaid for primary and acute care, for hospital care. It would not apply for people, applications submitted from the hospital. There will be no look back. It wouldn't apply to people applying in regular Medicaid offices just for regular Medicaid. So essentially, if the supplement A isn't needed, those of you familiar with this know that the supplement A to the application is used to document assets when people are looking for community-based long-term care. So my rule of thumb would be that if Sup A is required, then chances are a look back is required. So it might be delayed till after October 1st if we're still in a state emergency, or if the budget director has extended it after that. And also, it seems to me it can't be implemented until the state issues at least an ADM, administrative directive. I mean, there's a lot of detail and procedures that have to be fleshed out, and HRA and the local districts have to, develop procedures. I mean, this is a huge change, and systems and computer systems and trained staff. So I think October 1st is a little ambitious given that we're in this pandemic. And we know people at DOH are very consumed by dealing with this health crisis. So is somebody going to be sitting down and drafting procedures to implement a look back? I mean, I just don't see it. So, but we'll just have to see. It could be October 1st. It could be later. So how long is the transfer penalty? The law uses the same formula that's used in nursing homes. It says that they use the same nursing home rate. So here's an example. It's simple arithmetic. You don't have to be an advanced mathematician to figure out the penalty. You add up every compensated transfer in the look-back period, and then, so let's say there, Grandpa transferred $10,000 to 4 of his children, and they add up to $39,000. Okay. You divide that by the regional nursing home rate, which, as I said, in New York City in 2020 is $12,844. I'm rounding here. They have rules about rounding, but let's just say right now we just round it to 3 months. So the penalty period is 3 months. That Medicaid will not pay for community-based long-term care services. Let's briefly go over what the exceptions to the transfer penalty are. So a transfer to a spouse is exempt. There is no penalty, no matter how much is transferred. Transfer to the applicant's child who is certified to be blind or disabled, again, no matter how much is transferred. And note that that can be someone of any age. Usually when we think of a child as being disabled, people think of a minor child or a younger child. But a 95-year-old might have a child who's 70, and that person under this directive can be determined disabled for purposes of making a transfer exempt from the penalty. Since they're getting Social Security based on age, they don't have, quickly available proof that they are disabled. But Medicaid itself can make the determination of disability. If the person themselves is disabled and under age 65, they can put the transfer into a supplemental needs trust, and that is totally exempt. And even if they're not under 65, they can put it into a supplemental needs trust for someone else who is disabled under 65, a sibling, a cousin, a nephew. They don't have to be related. Transferring an exempt asset has no penalty. So Holocaust restitution, for example, is exempt, even if it's a $100,000 bank account. If it's all considered Holocaust restitution, that's exempt. So transferring that has no penalty. And the rationale there is it's okay for you to have it, so then it must be okay for you to transfer it. If you meant to sell the asset for fair market value, they can't judge, well, we think you gave too good a deal for this. So if you sell your car, well, the car is exempt. But if you sold stock that's worth, $500,000 for $10 to your son, that would be not fair market value. But there might be, prices lower than the market value that could still be. I think the question is intent, that you intended to sell it for fair market value. If you transferred money exclusively for a purpose other than to qualify for Medicaid long-term care. And this is the kind of exception that's been the subject of, hundreds of fair hearings because you're getting at intent. But the easiest example to understand this is that for someone who's really healthy, or let's take like COVID as a situation. Person is healthy and made a transfer, paid for the grandchild's college when they were like 70 years old, thinking they're going to live till 95, and then the next day they got hit by a car and now have lifelong injuries, total disability. So there was no way to know that they were going to get hit by that car. So that they weren't doing it as part of Medicaid planning. Another exception is all of the transferred assets have been returned to the individual, and that's true even if you just return part of them. That reduces the penalty. Then there are some complicated things I won't go into that the elder law attorneys use: purchasing an annuity, life estate, promissory notes, loans, mortgages. That's all beyond this presentation. There's also an exception if denial of eligibility would cause an undue hardship. And this is also something that there's lots of fair hearings about this in the nursing home context. I think it's going to have to be redefined in the home care context because it's just a different situation. But the basic criteria are that it would either deprive the individual of medical care, so endanger their life or health, or would deprive them of food, clothing, or shelter or other necessities. And they are unable to have the resources returned despite best efforts. And there are hearings that go into how much do they have to sue their child to get the money back. Which I'm not going into here, but it's an issue of how much cooperation and effort is required of the applicant to get the money back. And the exception that it would deprive the individual of food, clothing, and shelter. Now, in a nursing home, that doesn't really apply, but that will apply in the home care context. So, and certainly depriving them of medical care, that their health or life would be endangered, I think that will certainly apply in the home care context, because we know that the denial of home care can endanger the person's health or life. So I think that this hardship exception is something that we'll have to look into very closely. We'll have to monitor how the state implements it, to advocate that it be implemented in a liberal way. One of the criteria for undue hardship, I think, really has to go. It's from a 1996 directive that said that after payment of medical expenses, the individual's income and resources must be at or above the allowable, it will be denied if their income or resources are at or above the Medicaid level. So that basically means that anyone with a spend down cannot be eligible for undue hardship. And that, to me, makes it totally useless. And, maybe 30 years ago, the Medicaid levels were more reasonable when that was enacted 25 years ago. I mean, now we know that no one could live at $875 a month. So, again, it's an issue. I don't know how it's going to be interpreted. It's certainly ripe for advocacy. The procedures also say that you must invoke the hardship waiver at the time of application. And I think a lot of people could be caught off guard by that because you might not realize you need it. Let's say you were claiming one of the other exceptions in the application, and that exception ends up being denied. Well, then you'd want to claim hardship. So I think the advice will be always put in a request for hardship, just in case. That would be my tip on that. Denial of undue hardship, just like denial of any other exception, you could appeal that at a fair hearing. But just think about the delays in this. If all of this gets appealed, fair hearings, and all of this time, you are not getting services. Let's talk about transfer of the home a little bit. DOH has not set policy on this. Of course, this is all brand new. It's my view that the transfer of the home should be exempt for community-based care, but I'm not the state. I don't get to make the rules. But to me, it's just logical because the house is exempt when you're living in it. If you're on community Medicaid the house is exempt as long as equity is under the equity limit that applies for home care services. And this year, its limit is $893,000. And reminder that there is no equity limit if you live with your spouse or a minor or disabled child live in the home. So assuming that the home is under the equity limit, it's an exempt asset. So remember the exception with a few slides back that if you transfer a resource that's exempt, like Holocaust restitution, there can't be a penalty because you're allowed to have the asset anyway. So how could there be a penalty if you transfer it? Now, of course, this whole thing can be more complicated, but I think it comes down to that. And that makes it different than the nursing home context, because if you're moving into a nursing home, you're no longer living in the home. And that's why they can, in the nursing home context, impose a penalty if you transfer the home other than to certain favored, preferred relatives. But since you can own the home that you live in my view, you should be able to transfer the home with no penalty. We'll have to see how the state interprets it. So one thing that you're probably thinking of is that, gee, this sounds like this is going to cause a lot of delays. And let's see, why is it? I think it will cause delays. I mean, there are federal regulations that say a Medicaid application must be decided in 45 days or 90 days if it requires a determination of disability, and which is what's required if you submit a pool trust with your application and you're over age 65, for example. And state law has much shorter time limits for the immediate need applications. The whole application with home care approval is supposed to be decided in 12 days. Sorry, this got a little messed up down there. But we know that, there's a lot of applications. Everybody who applies for MLTC, it has to first go through their local DSS or HRA to get Medicaid approved. So they have a lot of applications to process. And it's time consuming, and this will obviously make it more time consuming. Our big concern, among many others, sorry, you can't really see that, I'll fix that, is that, many people apply for Medicaid, probably most people. They're going to look at their 2.5 years of bank books, and there's nothing but Social Security going in, rent going out, Con Ed bill going out, little cash taken for food. That's it. There's no transfers. There's nothing to look at. But that will still get bottlenecked in the local Medicaid agencies because it's still a project to go through all of these bank books. And of course, we've all had clients where I've had clients with very little money who opened 1,000 accounts because they got a free toaster when they opened this one account. So they come in with 8 different accounts. They have very little money, but boy, does that increase the time to review. Well, let's see which money went to that account and where did it get transferred to? And oh, it was just your own account. So even to prove that there was no transfers, it's a lot of work. And that's going to add work for the local districts. And do you think they're going to get more money for staffing this? Probably not. So it will inevitably cause delays. Big question people are asking is, can you still use a pool trust? Now again, I am not the state. I don't know what they're going to decide, but here's my view after talking about it with some of my elder law colleagues, is that pool trust should still be allowed for income. But let's talk about why there's even a question. The question comes in because federal rules define assets for transfer of assets penalties to include transfers of income. So it's sort of counterintuitive because you think assets are assets and income, there you think of them as being in separate buckets with separate rules. But the federal rules on transfers pull it all together and say transfers of income are transfers of assets, and they're all subject to penalties. So when it comes to using a pool trust or an individual supplemental needs trust, we know it's fine if someone is under 65 and they're determined disabled. Because if we go back to that slide on the exceptions, one of the exceptions was if you're under 65, determined disabled, and put your money into a supplemental needs trust. That's exempt whether it's income or an asset. But the question is, if you're 65 or over, that's not exempt for assets. It would have a transfer penalty. So my own view, again, and that of some of my elder law colleagues, is that there is good guidance, both from the state and federal government, that says as long as the pool trust has paid for expenses that meet the needs of the individual, there's no penalty for nursing home care, and by the same reasoning, there should be no penalty for home care. And this slide shows both the state guidance and federal guidance in the CMS state Medicaid manual. Another issue with pool trust, reason why we think it should still be allowed, is that one of the reasons pool trust can't be used in a nursing home is that a different type of budgeting is used in a nursing home for Medicaid, and it's called post-eligibility budgeting. And those rules are very strict. They do not allow the deductions that usually apply in the community. For example, in the community, everyone deducts the first $20 from their income. That doesn't happen in a nursing home. The earned income disregard that applies in the community doesn't happen in a nursing home. The only the only deductions that do happen are for health insurance premiums, and I believe the aid and attendance of the VA, which is just simply exempt income. So, but at home, you don't use post-eligibility rules, you use community eligibility rules. And so it's a deduction from income, and that's allowed in the community. Again, my view, I don't get to write the ADMs. I wish I could. Now here's, to me, the thorniest issue I saved for last about the look back. And this is going to make your head hurt a little bit. Because it's hard. So the new law says the period of ineligibility, that's the penalty period, shall begin the first day the otherwise eligible individual is receiving services for which Medicaid would be available based on an approved application, but for the transfer penalty. So what's the critical words there? It means the first day the individual is receiving services that Medicaid would pay for. So in a nursing home, when you apply for nursing home Medicaid, you are already in a nursing home receiving services. Since the DRA was enacted in 2006, you can't even apply for nursing home Medicaid until you are in a nursing home. And that was a change then, but we all got used to that change. And now you can only apply in a nursing home and you're already receiving the services. So the penalty can begin in the month of application or during the retroactive period. So let me show you an illustration of that. Okay, so you can sort of follow it. In a nursing home, let's say someone transferred $40,000 October 1st of 2019. 2 years later, let's say it's January 1st, 2021, they enter a nursing home. And nobody's paying. They're going to apply for Medicaid. They get a few months to put together their 5 years of records. They don't have to rush to file the Medicaid application, because even if they file it on April 1st, they can ask that the application be retroactive back 3 months, all the way back to January 1st, because Medicaid can be retroactive up to 3 months. So that's great. It gives them 3 months to put together all those records. Meanwhile, maybe the nursing home is asking them to pay the estimated NAMI, which is sort of like the spend down that's due. They do a back of the envelope calculation, and they agree to pay that, fine. But meanwhile, the nursing home is not thrilled about this because they're not getting paid. They can't bill Medicaid until Medicaid is approved. So you're Medicaid pending, but they're used to this. They're used to dealing with the cash flow issue. 45 days later, exactly on the deadline, Medicaid approves the application. They say, all right, you have a 3-month penalty, so you're responsible for 3 months, but we're approving you retroactively all the way back to January 1st. And so your penalty will run the 3 months from January, February, March, and Medicaid will start covering April 1st. Now, in reality, usually these applications take longer than 45 days, especially if there's spousal cases take longer because you're dealing with both of their lookbacks. But the fact is, in the nursing home, it's only the nursing home that's hurt by that delay because they're not getting paid, but the person is getting the services that are medically necessary that they need and they wanted because they went into the nursing home. So even if the application wasn't approved till August, the client isn't hurt by the delay. The result will still be the same. There's 3 months penalty that the nursing home isn't paid. Maybe the family can transfer the money back to pay it. They work it out somehow, but Medicaid will start paying. But let's go back and see what happens in the community, this bottom paragraph. In the community, you can't receive home care that Medicaid would cover until Medicaid is approved, because you have to be determined eligible for home care, either by the conflict-free assessment that New York Medicaid Choice does, or by HRA or your local Department of Social Services in a prior approval system. You couldn't get Medicaid home care services even if you wanted to pay for them. You can't enroll in an MLTC privately. You can't purchase CDPAP services. Even if you hire ALICSA, a licensed home care services agency, they are the agencies that generally that are licensed to provide home care services. And you can private pay them, but technically they are not Medicaid providers. Some are because they have a contract with HRA. or the local Department of Social Services in your county. And when services are approved by HRA, by the CASA, then they can bill Medicaid. But otherwise, they are not Medicaid providers. In the home care world, the only Medicaid providers are CHAs, Certified Home Health Agencies. And no one really hires them privately because they're just too expensive. Because they're meant for people with more skilled needs, and you have, by law, the certified in CHA means there's a lot of nursing oversight, there's weekly nursing visits. So you're much more likely to hire ELIXA, the Licensed Home Care Service Agency, and they're not Medicaid providers. So trying to figure out what is it going to look like to start this penalty date, and I still haven't figured it out. I had to give up. But just trying to think it through, if you'll follow me, same person, they transferred $40,000 in October 2019. 2 years later, January 1st, 2021, person starts needing care. Family does what family does. They're doing some care informally. They're private pay, ELIXA, a licensed home care service agency for some. Now we have to do a look back. They get all their records together. April 1st, they file the Medicaid application. They request retroactive Medicaid back to January 1st. They'd like to get reimbursed for some of the money they paid the ELIXA. May 15th, right on the dot, 45 days, HRA approves the application. They even approve it retroactively because person's assets were under the limit. And they assess a 3-month penalty. Now, what is the first day? Look at the bottom here. Here's the definition of when the penalty will start under the statute. The first day the client is receiving services for which Medicaid would be available, but for the penalty. Well, the first time they can even get the conflict-free assessment, I guess they could have gotten it any time after they filed the Medicaid application. But then they have to still enroll in an MLTC plan. So you really wouldn't be receiving services until you're ready to enroll. So that means you signed an enrollment form for a plan that you can't enroll in because there's a transfer penalty. So I have no answers here. I am raising the question. I don't really see how it's going to work. So to me, what has to be done is there needs to be an extra part of the procedure way back at the beginning or with the application where you file the Medicaid application and get a determination of need then and eligibility for the services, which if it's done by HRA is even more work for them. Or maybe Maximus does it way back on April 1st, so that when you're determined eligible, the penalty would start running around the time you apply. But any way you look at it, it's not going to be as favorable as it is in a nursing home. And to me, that raises questions about the Olmstead law. If it works so much better in a nursing home than in the community, and if services are just endlessly delayed because the penalty period can never start running, and that's going to push people into nursing homes, the state has a real ADA problem. The only guidance on this on a federal level, applying the transfer penalty to the home care situation, is guidance that applies for 1915C waivers. And I guess that footnote fell off here. but I can provide that to you if you want it. And that guidance says that the penalty begins when you'd otherwise be receiving home care services at the required level of care, instead of when you are receiving services. So that's a little better, but it still raises extra problems that there has to be some eligibility determination of whether you're receiving the required level of care. And they need to count if people are using informal care or care by non-Medicaid providers. Because if they're only going to count the time against the penalty if you are receiving care by Medicaid providers, only the wealthiest people will ever be able to run out the penalty because they can pay for a CHA. But none of our clients will be able to. So raising questions here, no answers. And Haley, should we just take a few questions on the look back?
Sure, I'd be happy to go through some of the questions that we've been getting now. And if anyone needs to clarify further, feel free to unmute yourself or respond further in the chat if we need any more clarification about the questions.
Let's just take like 2 questions because we don't have a lot of time.
Sure. Okay. One of the first questions, just to confirm, this 30-month look-back period will only be enforced for those whose applications for community Medicaid are reviewed after October 1st.
That are submitted after October 1st. Right,
okay, so
right. So, I mean, look, can they try, if DOH, it's my reading of the law that it would only apply to applications filed after October 1st. Now, again, I'm not DOH. They might say people getting services now, when they put their renewal in after October 1st, they're going to do a look back. I don't think that would be comply with the law. I don't think that's authorized by the law. But again, it might be possible. I think that would be challenged. I think it's for applications filed after October 1st. Now, if someone has Medicaid now, but they never did a Sup A, I would say now's the time to do a Sup A and ask for an upgrade in coverage, because if they do it after October 1st, so I think it's a request for an upgrade in coverage after October 1st, even for people who are on Medicaid or MSP only now. So that might be something, it's a good point. I think it's new applications or upgrades to that full Medicaid where you get community-based care.
Okay, great. And then one other question we have that came in, is the accommodation still in place for a family member who has been a live-in care partner for a homeowner for at least 2 years when the homeowner can transfer the home to that person without impacting Medicaid eligibility?
Okay, so that's one of the exceptions of the transfer of the home in the institutional setting. Okay, so that's an exception that the law says if you're receiving an institutionalized person may make these transfers, including the caregiver child or a disabled child. My point was that the transfers of the home shouldn't be penalized, even if you transfer it to your 8th cousin, because the home is exempt while you're living in it. You see, so in the institutional context, they allow only certain transfers to certain relatives, like that caregiver child, because you're no longer living in the home when you go to a nursing home if you're permanently placed. So that's why they limit which family members or people you're allowed to transfer to. I think that in the community, it should be more liberal because you're allowed not to transfer the home. So I mean, you're allowed to just live in the home and it's exempt. So this is the kind of thing that we'll just have to see. At the very least, I think, yes, I think those exceptions will apply because they can't make it worse than a nursing home. But I think it should be more liberal.
Okay, we have some other questions, but maybe we can get to those at another time so we can move through.
Okay, all right. So now we're going to, thank you, Haley. We're going to move through to some of the home care changes. And again, all of these, none of these are effective until after October 1st, some of them later. So we'll start with the biggest change and who is eligible for personal care or consumer-directed assistance. So just as a backgrounder now, if you need any assistance with activities of daily living for 120 days or more, you can enroll in MLTC, right? That's the minimum criteria. Even if you don't need assistance with activities of daily living, you can be eligible for personal care known as Level 1 or housekeeping services, which is limited to 8 hours a week, and you can get that from HRA or your local Department of Social Services. And sometimes those activities are called instrumental activities of daily living. And these are things like shopping and laundry and cleaning, meal preparation. And the idea is that you do have medical impairments that do interfere with your ability to live, but you are still able to do your personal care services on your own. You can bathe and dress and walk without help, but carrying that laundry bag is another thing. And all of these services are available whether you're on Medicare, in which case you get them through MLTC, or if you're not on Medicare, you get them from your mainstream plan, and some people still get them through their local Department of Social Services because they're not in these plans. So what's changing is after October 1st, 2020, or it could be delayed, the Level 1 housekeeping service, as I read it, will be eliminated. I mean, they're defining personal care as for only people who have 2 or more ADLs. And they must need limited assistance with physical maneuvering with more than 2 ADLs. Or if they have dementia or an Alzheimer's diagnosis, they must need at least supervision with more than 1 ADL. In other words, 2 or more ADLs. People already receiving personal care, housekeeping, or CDPAP as of October 1st are grandfathered in. They will not be under these new limits. So an MLTC plan can't say, we're kicking you out because you only need 2 ADLs. You have only 2 ADLs. They're also going to be introducing a new evidence-based validated assessment instrument by which they're going to determine all this. That will be rolled out later and be approved by the state. So after October 1st or later, whenever it's implemented, New York Medicaid Choice will be using this new standard to decide who is eligible for enrollment into an MLTC plan. And HRA and the other local districts and mainstream plans will be using it to determine who is eligible for personal care or CDPAP. Now we want to thank, we know Assemblyman Gottfried and State Senator Rivera heard concerns from many advocates about the original MRT proposal was to limit it to assistance with physical maneuvering with more than 2 ADLs, with no exception for dementia. And NYLAG and other advocates called them out on, just plain and simple discrimination against people with cognitive impairments. And so they did make that exception, but it's still very strict. They have to have 2 ADLs. Now let's look at what they don't define ADLs in the law. So again, this is my guess of what the ADLs will be. And I got the top list of 8 ADLs is from the UAS. It's from the Uniform Assessment System nurse assessment that is now used by HRA, by MLTC plans, by mainstream plans. And in the area, they also don't call them ADLs, but so you recognize these tasks. These are the basics. They break out on the UAS. It breaks out dressing upper body and lower body separately. So maybe we could say that's 2 ADLs. I mean, look, for the severely impaired, this is not going to be a problem, but they'll hit most of these. But my big worry are the people who are, frail and fragile, but not, they're still ambulatory with assistance. They're still, but everybody knows they shouldn't be alone for the time where they're up during the day. Then the state regulation has a few other things listed as personal care tasks. I don't know that they would consider these ADLs. It seems that they're more just permitted personal care tasks. So in addition to what ADLs, we have to look at, well, what is this whole thing about physical maneuvering? So unless the person has a dementia or Alzheimer's diagnosis, an ADL will count towards a 3 ADL minimum only if the person needs limited assistance with physical maneuvering. So that phrase appears to come right out of the UAS, the nurse's assessment, and we have a copy of the UAS instructions on file, and it defines the 7 levels of assistance with ADLs. And the ones that are highlighted, you can see limited assistance is number 4. And the definition of limited assistance is guided maneuvering of limbs, physical guidance without taking weight. So you must meet this minimum. And you could see, above that is extensive assistance, maximal, total dependence. But below that is supervision, oversight, cueing. And that will not count unless there is a dementia diagnosis. So it's hard to tell right now how much of a problem this will be, but I think now we should all be paying attention when we review UASs in our advocacy. Just start paying attention to see what with the lower need people, is this going to be a problem? Are we going to be really fighting out whether, no, this is not just supervision, this person needs limited assistance? And I think there'll be more cases where we'll be appealing a Maximus decision to say, no, you're not eligible for enrollment in MLTC because you don't need have 3 ADLs. And until now, Maximus only denies something like 1 or 2% of all people MLTC enrollment, because everybody meets the standard. If they feel they need home care, they're usually found to need it. A few get sent back to HRA for housekeeping, but that won't happen anymore. There'll be no more housekeeping. So I think this is the biggest change, but let's go through some of the other changes quickly. I think most people are familiar with the M11Q form, which is the physician's order for personal care, and it's always used for CDPAP services by plans, by HRA, and it's often also used for personal care, although many of the plans don't use it for personal care. On the books, it is required for personal care. So the change is that who fills out the M11Q, that personal care and CDPAP must be prescribed by a qualified independent physician selected or approved by the State Department of Health. And the law says the state can use Maximus. So Maximus will hire a bunch of physicians all around the state, and they're going to be the ones to complete the M11Q. I mean, that seems to be what's intended. So, you know, there's a lot wrong with this. I mean, one of the top spaces on the M11Q is how long have you treated patients? And, you know, we have clients, 20 years, 5 years. Physicians know their patients over time. They know how their condition has changed over time. Some of them specialize in a particular diagnosis that the client has. People with MS and Parkinson's have neurologists as their treating physicians because they are specialists in these diagnoses. So who is going to be on this panel? I doubt that they're going to have a lot of neurologists. And how will people get appointments with these physicians? I'm picturing people up in Rome, New York, and Tupper Lake. You know, how will they be seeing these physicians to get a prescription? Will they do home visits? So again, no answers, just a lot of questions. And what kind of delays will be involved in getting appointments with these physicians? Now, if they're trying to eliminate the treating physician's input in advocacy, I don't think that they can. I mean, it might be that this contract physician is the one to fill out the M11Q, but to me, you know, it's a free country. The person could still get a letter or statement from their physician and submit it to be considered. And I think the best practice will be to get that statement and even give it to this qualified independent physician. So they have it at the time of when they're doing their assessment. They'll have the benefit of the treating physician's input and knowledge and familiarity of this person. Certainly at a hearing or an appeal, there's nothing to prevent someone from submitting the views and observations of their treating physician. But the state's clearly trying to cut it out because the treating physicians can explain what's medically necessary, and they don't want that. Excuse me. There will be a new task-based assessment tool procured by the state. That's on a longer timeline, but it's still pretty fast. It's just a year from now. And as I understand it from their description of it in the statute, is to assist the plans and the local DSS to make determinations for the number of hours. So this would not be to replace the UAS. I think this would be to supplement the UAS, to translate the findings in the UAS to a number of hours. Because now, if you look at the UAS, there's nowhere in the UAS where it actually says, you know, spits out a number of hours. The plans do that on their own. They have their own proprietary tasking tools. HRA used to have, and maybe still has, a task-based assessment form. And there are rules. There's state policy that's based on litigation that says when they can't use these pastimes because someone has 24-hour needs or someone has scheduled and frequent needs. So all of that should still be true, but I think, again, this will be another barrier. Now, this sort of makes you laugh. The tool is supposed to identify how the need for assistance with ADLs can be met through telehealth. Now, this brings me back to the 90s when I was one of the lawyers litigating the lawsuit where HRA told people with 24-hour care, we're going to give you a PERS, the Personal Emergency Response System, and we're going to reduce your hours from 24-hour care to, say, 6 hours a day, because now you have a personal emergency response system. That the suit immediately settled because both the state and the city realized that a PERS does not really substitute for an aid in helping you to the bathroom. And telehealth, I sort of fail to see, except by maybe prompting someone to remind them to take their medications, how it would provide any personal assistance or reduce the need for it. And the tool also needs to assess whether family and social supports are available. And of course, we're all for family providing care. Heaven knows they provide more care than what is paid for through Medicaid. So we have no problems with that. If anything, it could improve it. Like now we see MLTC plans just assuming that family is available because they might live with the consumer or live in the same geographic area, but they never ask, well, when are you available? When do you work? When, what are your other commitments? You have a 2-year-old yourself. What? So this has always been a big problem. So if they do it well, that could be a help. If they don't do it well, of course, it will be more problems. And this is big. DOH is going to appoint an independent assessor to replace HRA, the MLTC plans, and other CSS and managed care plans in determining the number of hours. Now, this is on a longer time frame. This won't be established till October 1st, 2022. So that's a relief. It's about 2.5 years now down the road. The law actually says this could be Maximus. So Maximus made out very well in this budget. They're expanding their contracts by probably millions and millions and millions of dollars. And it's not clear exactly what this independent assessor will do and how it will coordinate with the local districts, with MLTC plans. But again, they just, I guess they want to shrink the hours, and they think by having someone independent, they will do that. It's hard to imagine shrinking them to less than what the MLTC plans authorize. And it's not clear really what the MLTC plans will be doing once this happens. All right. Then there's language in the budget about, as they establish standards and they establish these new tools for managing and assessing need, the standards used in the Olmstead decision must be used to consider whether an individual is capable of safely remaining in the community. And this language was added to the personal care definition in the statute, to consumer-directed definition. Now, what's the reference to Olmstead? Some of you might be familiar. This is a U.S. Supreme Court decision now. It's 21 years ago, written by Ruth Bader Ginsburg, the Honorable Justice, that held that unjustified institutionalization is a form of disability discrimination under the Americans with Disabilities Act, and that states must provide Medicaid services in the most integrated setting as a reasonable accommodation to avoid that discrimination. Now, of course, it's complicated. It can't be an undue burden on the Medicaid program to provide the services, so that there are limits. What goes into being a reasonable accommodation is something that's litigated, and there's a lot of regulation about it, but that's the general idea. But when they talk about whether someone is capable of safely remaining in the community, it raises some red alarm bells for those of us who do disability advocacy, because safety is often used as a pretext to deny services. I mean, let's face it, most times we see a plan saying you're not safe at home, you must be in a nursing home. The subtext to that is we don't want to authorize 24-hour care. And without that, you're not safe at home. Now, if cost was no issue, they would be authorizing the care. And New York's program still covers 24-hour care. That has not changed. That has not changed in this budget. So when we see safety, we have to be concerned that that is a pretext for denying the care that is more expensive and can be used as a pretext for deciding that someone would need to be in a nursing home. Now, in the personal care service, they've mentioned this a few times in the budget law. And the second time they mentioned it, the first time was in the definition of personal care. That's what we just looked at. For personal care, the law goes a step further, and it authorizes the state to adopt standards by emergency regulation for managing and assessing services for individuals whose need for services exceeds a specified level to be determined by the state. Now, it doesn't say how much, but when the MRT recommended this change, they said this will apply to people getting 12 or more hours a day. So bingo, what did I say? I said they don't want to spend the money on giving the services they need to keep people at home. So they're going to scrutinize people who have 24-hour needs and assess whether that consumer with the provision of services is capable of safely remaining in the community. So who gets to decide what is safe? In the disability community, there's a concept known as the dignity of risk, the right to choose, to accept some risk that may exist in the community in order to live at home as they choose. Now, of course, they shouldn't be put in the position of having to choose inadequate hours of care in order to live at home. They need to have sufficient care that's within the levels authorized by the state's program. One of the ADA regulations, I think, will be applicable as we look at this, and it says it warns, this is a 30-year-old regulation, that when a public entity may impose legitimate safety requirements necessary for the safe operation of a program. However, it must ensure that safety requirements are based on actual risks, not on mere speculation, stereotypes, or generalizations about individuals with disabilities. And I think, we can expect that safety has already been an issue. I know in our office, we've had cases where plans have said, sorry, you're not safe at home. You have to be in a nursing home. And these are going to be a hard-fought issue. And it's not new. I mean, this has been an issue going way back to 1992 ADM. Reasonable expectation of safety has always been required. And there have always been fair hearings, on this issue. But we can expect that this will come into play more. Some other budget changes. You may have heard that the Consumer-Directed Personal Assistance Program has been sort of a target of cuts for the last few years. And the state is basically blaming this program for the growth in MLTC enrollment. MLTC enrollment is now up to over 250,000 people in New York State, and it has grown fast. And the state blames the CDPAP program, but they also forget that they handed over administration of this program to insurance plans. That's what MLTC plans are. And what do? They market. There are still ads. I saw Village Care ad just last night on TV. I mean, they do ads, they do marketing. And so, as do the fiscal intermediaries, as do the LICSAs. So they sort of made their bed, and now they're blaming all the growth on the CDPAP program, which seems really unfair and misguided. So the CDPAP program plays a very, very important role in giving people flexibility to hire trusted family members as caregivers. Aides can do skilled tasks that normally are prohibited for personal care aides, and they have the flexibility. And now with the COVID crisis, CDPAP is more essential than ever because people are afraid of aides commuting, traveling, exposure to the virus, and now CDPAP more than ever can be relied on. A daughter who's now out of work can become the mother's aide, and that's a wonderful thing. So one change is that until now, a new applicant for home care, one of the many things they get when Medicaid is approved is a notice of the availability of consumer-directed program. That will end. They took that out of the law. It says you have the opportunity to apply for CDPAP no less than annually. We don't know exactly what that means, but potentially the state could try to limit enrollment in CDPAP to only once a year. I don't see how they can because it's a state plan service, which has to be available to any Medicaid recipient. So it's not a waivered service. So I don't see how they could do that, but they might try. And there's been a series of cuts in CDPAP over the last few years. So they didn't cut it as badly as was threatened, and I think because they have a very active lobbying team. They cut a lot of money out of recruitment and retention funds for CDPAP. That was really critical, especially upstate where there's such a shortage of aides. And some of the CDPAP agencies were able to pay a higher wage to ensure that they could attract aides in rural areas. And they just simply eliminated this bucket of funding. I guess the thinking was, well, CDPAP has grown, so they apparently don't have any trouble attracting aides. But that's just not the case. All right, another thing just to be aware of down the road is that the state wants the MLTC plans to morph into becoming total capitation plans, meaning that instead of covering only Medicaid services, they want to merge with Medicare Advantage plans to become all-in-one plans. And the models for those are Medicaid Advantage Plus or PACE. There was a third type of model of that, which was FIDA, and that program ended because it wasn't popular. But I've given you the numbers here, and you can see there are almost 10 times as many people who choose to be in MLTC plans with separate Medicare coverage, keeping that coverage separate, than people in Medicaid Advantage Plus and PACE plans. So we can expect to see this changing. They want to really push the MLTC plans to develop relationships with Medicare Advantage and become these all-in-one plans. And there's a moratorium on any new MLTC plans launching or expanding their service area. And there's going to be a cap on growth for certain MLTC plans. And we can look, just looking at some of the numbers of recent growth. I look at this data is all available on the state's website. The largest plan in New York City right now is Center Plan for Healthy Living. It has 35,000 enrollees. That's how many there used to be in the city's home attendant program totally. It used to be about 42,000 at any time, because there's now 190,000 people in MLTC in New York City alone. And just these two plans have more than 25% of those people, Center's Plan and Integra. Look at how much they've grown. Center's Plan's grown 23% in a year. Integra's grown 68% in a year. And this is not from any mergers or acquiring other plans. This is just growth, probably marketing. Whereas the whole growth in New York City in a year is 12%. So for the fast-growing plans, my guess is they would target these two plans and maybe some other plans. They're going to withhold 3% of their premium. And if they exceed the cap that's going to be set for growth on these fast-growing plans. So my concern is that how will the plans control their growth? They're going to look to reduce enrollment and by rejecting consumers with high needs, because the state isn't telling them who to enroll. It's still allowing them to pick and choose who they enroll, which allows something called cherry picking, which means that they will still want to enroll people with lower needs. And I think everyone has seen a problem with, you have an MLTC come and assess your client, no matter what their needs are, they say, we'll give you 4 hours a day, we'll give you 6 hours a day. And what are they doing? They're deterring enrollment of high need people, because someone with high needs will simply not want to enroll in that plan. And that's what they're doing. Now, if you enroll in that plan, you can still appeal, you can fight for more hours, but that takes time. And chances are you won't find a plan willing to give you the hours you need anyway. So this is not going to help this particular problem. All right, we have time just to run through some COVID-19 protections. I can stay later and answer some questions if you can stay after 11. That's fine. So some protections, and these were required by the Federal Stimulus Act, saying states just can't let people fall off Medicaid at this time when Medicaid is critical. So no Medicaid can be discontinued after March 18th until the end of this emergency. And so that means, like, if a case was up for renewal, even if someone didn't submit the renewal package HRA and the other local districts have to just put it through and automatically renew it. Even if someone reports changes that say, you know, I got a new job and I'm now making $1 million a year. You know, that's not likely with 30 million people unemployed, but HRA couldn't discontinue. They can't reduce Medicaid. They can't increase the spend down for anyone during this time. Even if someone lost SSI or public assistance, and usually they go through that Stenson or Rosenberg process. Those processes might still happen, but in the end, their case can't be closed, and it's my understanding that the processes won't even happen. They're not getting those renewals. HRA and the other local districts are just putting up coverage. If they met the spend down just for 1 month in March or later, HRA and the other local districts are putting up full coverage for 6 months. Again, some of this is because, you know, HRA staff are affected too. I didn't mean a pun there, but unfortunately, it's true. People are getting COVID, you know, among city workers and county workers, and they have less staff to be able to be processing all of this. Plus, they're trying to work remotely without systems that were ever really designed to work remotely. So, you know, we really have to hand it to HRA and the state for, you know, quickly adapting these huge systems that are hard to, you know, with, you know, 40-year-old computer systems. None of this is easy on them, and they're really working to keep the system going and keep people on coverage. So by the same token, just like you can't lose Medicaid now, it's easier to apply for Medicaid. HRA has launched some e-fax options for submitting applications, one for people in CREP, one for the public. You can now attest rather than document income and assets. So when you fill out the application, normally you have to supplement it by verification of income. Now you could just say, here's my income, here are my assets. And that's even true for nursing home eligibility. Right now, if you're submitting, you don't have to do the 5-year look back. You can say, I didn't make any transfers. My assets are under $15,750. You don't have to apply for Medicare right now if you're not receiving it automatically. You still need to complete the application. You need to complete the Supplement A, but you don't need backup. The one backup you need is for citizenship or immigration status. But even there, HRA has ways of verifying your status, and if they can't verify it and you don't have the documentation, they will put up 90 days of coverage while you have time to obtain documents, and that can be extended 90 days more. If there is information needed, this HRA and the other local districts have to make an effort, instead of just denying the application or sending out an RFI request for information, they call or email the applicant, accept the info by phone. So there's a lot of flexibilities. Hearings are all being held by telephone. And now, and advocates can email documents to the email here in advance of the hearing. And there's a gist that was put out by the state. In home care, there are flexibilities. The UAS assessments can mostly be done by telehealth or by phone. There is some gray area about the conflict-free assessments. The state has issued some guidance, which frankly is really hard to understand. They talk about partial UASs. So both the HRA and us are trying to get clarification from the state. But I understand from hearing people that Maximus is doing telehealth, conflict-free assessments. And if you've had a problem getting a conflict-free assessment, you can email me. I'm interested to hearing about those issues. But I've heard that they are doing them. Also, if there's long delays in getting them, let me know. The M11Q can be signed by the doctor using a telehealth or telephone exam. They can even phone it in to the MLTC plan or to HRA or DSS, but I believe those procedures are still being set up. Where do they make the call? Who takes the call? I don't know yet if those have been set up. CDPAP assistants are not required to get an annual health exam, but they still have to get the initial exam and vaccines. And I just saw guidance that for LICSAs, the LICSA aides can get their annual health exams by telehealth or telephone. And I think even their initial onboarding exam by telehealth, but they did not do the same thing for CDPAP. All right. Oh, we're right at 11 o'clock. All right. So let's, Haley, do you want to read some more of the questions? If people can stay on, I'm glad to answer some questions. Haley will read a few, and then maybe we can open the phones and stay on for 10 or 15 minutes.
Sure. I'm going to go through the few COVID questions that we have first, and then I'll go back to the rebudgeting and some home care specific questions.
Great.
Will clients be responsible for providing the spend down that was waived during COVID at a later point?
Okay, I don't think so, but it's a great question. I believe HRH is putting up the coverage for 6 months, and that'll just be put up. We haven't heard, we have asked, but haven't heard how that works with MLTC. If it's also just they don't have to pay it during the 6 months. I have not heard anything. So, but the issue is activating Medicaid and keeping it going. So when you're submitting your spend down or paying in to Medicaid, the HRA or your local district, you need to do that to even get Medicaid active. And that's why they're putting it up for 6 months, because otherwise your Medicaid would be discontinued, and that could, conceptually violate the requirements of the maintenance of effort continuity requirements of the federal rules. In MLTC, you have active coverage because you're deemed, you're just billed for your Medicaid. So I don't know, like no one's cutting off your Medicaid for failure to meet the spend down. But I would argue that you can't be disenrolled for not paying your spend down now. And we haven't gotten confirmation of that yet from the state. If anyone is getting threatened with disenrollment for not paying the spend down, please let me know. Please get in touch with our unit.
Okay, great. Let me move on to some of the other questions. Can the e-fax be used for Medicaid eligibility questions at this time?
E-fax from eligibility questions. I don't know. I mean, I think they set it up for actually filing applications. So I think they still have some phone numbers. The EIS unit is functioning under very, very limited staffing, and there's also the hotline. So I don't know. I think that question has to be addressed to HRA.
And do you have any suggestions for clients who canceled their home health aides due to COVID? How may they reinstate their home care services in the future if they receive a suspension notice? See any problems coming up with that?
Yeah, I definitely see problems coming up. So I'd like to know what that person means by a suspension notice. Are they getting disenrolled from their plan because they have refused to accept the aid? Because we have asked the state that they should not be disenrolled now, because all they need is, it would really be disruptive of continuity later. So I would appreciate whoever asked that question to email me, email vbogart@nylag.org, because if anyone has actually been threatened with disenrollment or discontinuance of the service, I'd like to know about it, because I don't know. You know, we haven't been through a pandemic before. So all of this is new, and, you know, DOH is trying to keep up, and we're trying to advocate with them to make some consumer-friendly policies on this. And this is one. It's a big concern because we're afraid that if someone is disenrolled, when this is all over, September, October, whenever it is, they have to go through the conflict-free again and get back into a plan, and maybe the new plan won't give as many hours as they had, that this would be, you know, very, very detrimental to them. So we're very concerned about that, and I have no answers right now, but I would contest any disenrollment, because I mean, I could see the state doesn't want to pay the plans for providing services, and they could work out some, it seems to me, some lower capitation payment. That's not really our job, but for continuity, I don't think they should be disenrolled, but have not seen anything.
Okay, I'm gonna move back to some questions about the budget changes. I think that was the end of the COVID related questions. So, and we'll just take a couple, and then from here, and we'll see how many we get to. Otherwise, we'll go about some way of getting more answers and information out, maybe via email. Be happy to do that. So let's see, does the change in the look-back period now for community-based services, does that apply to recertifications at all?
Okay, so that's a great question, and we don't know. I did try to answer that question, but maybe you asked it before. I put that up. I mean, I talked about it. I don't think it should apply to renewals of people who are now on and who renew after October 1st of 2020. Can they be then asked for a look back? I believe it's limited to applications, because I think that's how I read the law. So, but again, it's up to the Department of Health to figure out how to implement it. I think it should not apply. If someone already made a transfer, I guess, to be eligible, or if someone's transferring now and applying now, and then they're worried about it, you know, I can't say. I don't think it can be effective for people after in renewals. But again, it's my opinion and not state policy.
Okay. Another question came in. With the new law, would the penalty start date go back to when someone obtained MSP, given that it's a Medicaid benefit?
It obtained MSP? Is that what they wrote?
Yes.
No, it would not. I mean, the whole thing I was showing was about how the whole start date of the penalty is when you're receiving home care services, not any other Medicaid services. So it's a problem enough because you can't receive Medicaid home care services without being on Medicaid. So no, absolutely not. Receiving MSP or other Medicaid services would not trigger the start date of the penalty. But even within the world of home care, I think in the assisted living program is the place where it could probably work the closest to how it does in a nursing home, like the most favorably, because you'd apply once you're in assisted living. You might have to private pay for a few months because of the penalty, but you're receiving the services. So there, it seems like it could work pretty well. But in the home care situation, I think we just don't know yet how it's going to work. But no, that will not work.
Okay. And one question, is the understanding correct that housekeeping won't be a task that one will be able to get assistance with through PCA or CDPAP? Members will need to get housekeeping.
I'm sorry, I didn't hear the word. That what will be a task?
Housekeeping.
All right, great question. And I believe it will still be a task within the personal care program if you meet the 3 ADL requirement or 2 ADLs with dementia. So just like now, if you're in an MLTC, your aides still do housekeeping tasks, and the plan has to even authorize more than the 8 hours if it's needed. The 8-hour limit only comes from people who don't need any personal care and need only housekeeping. But those tasks are the IADLs, instrumental activities of daily living, which I believe, yes, the personal care aides will still be allowed and even required to do them. But to get them, you will need to meet that new ADL requirement.
Okay, I want to take a step back. We had
That's
another
a good
COVID
question.
We had another COVID question come in, so I want to make sure that one is answered.
Okay.
MLTCs seem reluctant to assess existing enrollees in subacute facilities. What is the best recourse of getting expedited reviews? DOH is stating that MLTC plans can conduct a standard review if they choose to do so. Isn't this against Olmstead?
Yeah, it's a great question, and this is like the biggest problem I think that's going on. Look, DOH guidance, the link is in here, says the plans can do telephone and telehealth assessments. So to me, that it's because they can do them, they must do them. If someone is eligible, ready for discharge, they have to do it. But if DOH is saying that not saying that they have to, I don't know what our recourse is to force them to. It's very frustrating. I would call the MLTC complaint line. My computer seems to be frozen. I can't get. I hope you all know the New York Health Access website. The news articles, there's always an MLTC update article. And at the top are key MLTC contacts, the state MLTC complaint line, the ICANN program. I would be calling both of those if a plan is refusing to assess someone for discharge. They can do it without sending their nurse. That's been made clear. And I just want to point out that we do have this COVID resources page. So there's a little table of contents here, Medicaid home care. So right here is the guidance that says allows nurse assessments to completed by telehealth and telephone. So all this stuff is here, very handy for you to find. You can see some of the advocacy letters that NYLAG, Legal Aid, Empire Justice have sent, asking for some of the things we've discussed here as what you're talking about. But I think it's just going to take a lot of advocacy. And you're right, I think it is an Olmstead violation, but we also know there are practical realities here about fears of an actual, exposure to the virus. But contact ICANN, you can contact EFLRP on these issues, and it's a matter of a lot of fighting. But none of it's going to be easy, and there are no easy answers. Excuse me.
Okay, do we have time for any more questions?
Sure, we can take 2 more. I understand some people are signing up, which they understand. That's fine, but we can. I'm not going anywhere, so
So just before we go into that, will a recording of this webinar be available for attendees?
Yeah, I think we can make it available.
Okay.
Yep. As long as we hope it recorded, should have.
I think it is. Okay, let's see. Will partial cap plans be eliminated?
Well, the budget reads as though they want to move toward that. I think that's going to be a long, long process, much more than a year or two. As I said, there's 250,000 people in these plans now. So in the partial cap plans. So it won't happen anytime soon, but it looks like they want to, the state wants to transition to that. And encourage the plans to become full capitation.
Okay, and one more question about the budget changes. There's a question about the exception in the slide for the 2.5-year look back for home care. Let's see if I can pull up that slide. I think it's slide 9 in the PowerPoint for reference.
Okay.
The slide indicates that spousal refusal is still in effect, but does not protect them from the transfer penalty. But the transfer penalty exception says there is none. We clarify this.
So, right. So the thing is that a transfer penalty is imposed if whether the applicant or spouse made a transfer in the 30 months that is not exempt from the penalty. So if the applicant transferred assets to the spouse, that's exempt. But let's say in the 30 months before, the spouse transferred $50,000 to whoever, a child, a grandchild, a neighbor, whatever. Now, let's say that spouse also has excess assets now, still. So they put in the application. The spouse does a spousal refusal because they have excess assets. Even though they transferred $50,000, they still have now $50,000 over the limit. All right? They can do a spousal refusal. Those current assets won't count for eligibility because spousal refusal still exists. But they must include the spouse's financial records with the 30 months of records. And the Medicaid agency, HRA in New York City, will see that $50,000 transferred by the spouse in the look back. And if that transfer was not exempt under one of those exceptions, then there will be a penalty based on that $50,000 transfer against the applicant. So the only way that the Medicaid agency would know that that transfer happened is by the spouse submitting all of their records for the 30 months along with the applicant. So that's why that you still have to do the look back for the spouse, even if you're using spousal refusal. The spousal refusal is about now. You're refusing now, today, to contribute assets or income. The look back is about transfers in the last 30 months. And that it's just a different concept. It doesn't, the transfer penalty is one aspect of eligibility and current income and assets are another. They're two different things and they seem to mush together, but they're really separate. And I know it's hard to get your arms around this, but these are the things that we have to start getting used to.
Okay.
Should we open up the phone for a minute? See if anybody.
If anyone has any other questions, you can unmute or submit a question into the chat. I'm still monitoring it. If we haven't gotten to your questions, I apologize. We do have some more you want to go through that list.
Okay, why don't you do one more and then we can just open the phone.
Sure. Okay, one more question. What is the future of adult daycare programs after October 1st, 2020? Because the program is covered by Medicaid. Do we know anything about that?
There's been no change in the Medicaid law in adult daycare. The change was because of COVID, that they were closed down because of COVID. And then again, on our COVID page, we have, having trouble with my computer to get back to it, but we have the state guidance there that the adult daycare program can still be open now for doing telehealth for their former members, and I guess the MLTC plans can still be or should still be paying them, and social adult day programs for doing that. So that was some later guidance. So the budget didn't change it, and I assume that if they survive the economic destruction caused by COVID, that they can reopen and go back to functioning. I mean, it's one provider that's really, very badly affected by COVID, but legally there's no change.
Okay. Some more questions. Again, is Medicaid not being discontinued until the end of the emergency or for the next 12 months? I've heard both answers.
Okay. I have not heard 12 months, but I think where someone may have gotten that is that HRA is putting up coverage for 12 months. Not the spend down situation. I think they're getting 6 months. But let's say you're just up for renewal. You're up for renewal. You're in April, and instead of going through that whole thing, because they don't have the staff there to process the renewals, and there's this national bar now to ending Medicaid. So as I understand it, what HRA is doing is putting up coverage for 12 months. So they're basically automatically renewing people for the whole 12 months that they would have gotten had they done the renewal, because renewals are usually for 12 months. So that's why so your next renewal wouldn't be for another 12 months. So in that way, indirectly, you can't be discontinued for 12 months. But I can't say that, like, after this is over, within the 12 months, if HRA's records show that you now are earning $100,000 a year in a new job, I can't say they can't discontinue you, right? Like, I don't know exactly what will happen after the emergency's over in those cases. I would think that if they have information that would disqualify you, that your Medicaid could be discontinued. It's not like a right, but I'm sort of, thinking, just off the top of my head now, but your coverage will be put up for 12 months. You're still required to report changes, but during the emergency period, they're not allowed to take any adverse action based on them. They're not allowed to increase your spend down. They're not allowed to discontinue. But if you've reported changes that affect your eligibility in a bad way, I think they can probably act on them after the emergency, even if it's within the 12 months. But with notice, you got to do 10-day notice, and you have a right to appeal. And all of that.
Okay, we have another question coming in. Do we know if the 30-month look back will include looking back before October 1st, 2020? For example, if someone applies for Medicaid home care on January 1st, 2021, will the look back extend back before October 1st?
Okay, that is a great question. And I meant to cover that, but I think maybe I deleted that slide. So I'm really glad you asked that question. So this is one of the big issues that we think either there was an oversight in drafting the law or something. So usually there have been many changes in the look back over like 25 years, since the early 90s. Like there was originally a look back, then there was no look back. And in 2006, Congress extended the look back from 3 years to 5 years. So the penalty the look back has changed over the years. Every time they've changed the law on it, they've always said this change is only effective for transfers after today. So when they extended the look back from 3 years to 5 years in February 2006, they said, all right, we're only extending it for transfers after February 2006. So what did that mean? It meant that in April 2006, the new change of the 5-year look back would only apply to transfers made in the last 2 months, right? So it wouldn't be a 5-year look back yet. It was phased in. So it would have been this old 36 months, the 3-year look back, plus the 2 months. And then every month for 2 years, they added on another month until you got to 5 years. So this time, they didn't do that. The law does not say for transfers made after October 1st, 2020. It still uses the old phrase for transfers after February 2006. So that means, unless the state says otherwise, the answer to your question is if you apply in January 2020, that they can look back 2.5 years. Not only just the 2 months since October 1st, 2020. So in other words, they're not phasing it in. It's just 2.5 years. Now, look, I and some other elder law attorneys think that's really unfair. If someone transferred assets 6 months ago, they knew they were taking a risk that they couldn't get nursing home care in the next 5 years, but they didn't know they couldn't get home care. Maybe they would have done something differently had they known. They went to an elder law attorney, or they went to one of you, and you told them, look, you're going to have that risk. You're not going to be able to get nursing home care within 5 years. And they'll say, okay, fine, I understand that risk. I will take that risk. But I'm glad to hear that I can still get home care if I need it. So they're changing those rules retroactively, really. It's like, no, we're changing the rules. You can't get the home care based on the transfer you made when the rules were different. So whether that can be legally challenged, I don't know. It certainly seems at the very least unfair. And but that's how the law is written, is that it would apply to those transfers. I hope that answers your question, but I know that it raises other questions.
I have another question for you here. Regarding fiscal intermediary CDPAP agencies, is it true that most CDPAP agencies will be eliminated as a part of the budget? How will we know which agencies will still be around?
All right, well, they actually were not eliminated. Last year, in the previous budget, they passed a law that says that all the fiscal intermediaries have to become a contractor of the state and licensed by the state. So that in itself is going to eliminate some because they all won't get through that process. And I think the state is deciding there how many to contract with. So that's where they're really cutting back. And I didn't mention that the same things happened in this year's budget for LICSAs. Licensed home care service agencies must now contract with the state, which is a huge change. They've always been licensed, meaning they have to meet certain regulatory requirements, so many nurses on staff, so much, various hygiene requirements, record keeping, liability requirements, they have to meet a lot of requirements, but they didn't have to actually negotiate a contract with the state. So that happened last year for fiscal intermediaries, and it's happened this year for LICSAs. So for both, it's going to greatly reduce the number of both FIs, fiscal intermediaries, and LICSAs. And will that affect access? Probably. It probably will. Will we get a list of them? I don't know. I mean, this is going to happen over some time because the state's also really taking on a lot of work. There's something I've heard like 1,500 LICSAs, which doesn't surprise me because just on my block in Brooklyn, there's like 4 offices. They've really sprung up a lot. And fiscal intermediaries, we know that new ones have sprung up. So they're not phasing it out, but there will be fewer, and I think, and my guess is it will affect access.
Okay, just a reminder that there's a PDF and the PowerPoint available in the handout section of the webinar for download. Speaking of that, will a PowerPoint be available on the New York Health Access website?
Yeah, I'll probably just tweak it and make a few of these changes, and then we'll post it on the website. Yeah. Okay. So let's just open the phones just for a few minutes and see if anybody wants to ask a live question of the few who are still on.
Sure. Let's see if I believe people are able to unmute, but I'll go ahead and just unmute everyone.
We'll see if it works. If it doesn't.
Their audio should be available if anyone has any questions.
Okay, any last questions? We'll take 2 or 3. Or maybe everybody's asked them.
Will there be time to make an announcement?
Will there be what?
Time to make announcements?
Oh, yeah, sure. You want to make some announcements? There were some made earlier, but you can make some.
Yeah.
Sure.
Hi, this is Michelle Bernay with the New York City Department for the Aging and the HICAP unit. And I just wanted to make sure that people know that HICAP is open and available to people with any Medicare counseling questions they have. We're working, I guess, quite logically with a lot of people who are losing employer-based coverage and need to enroll in Medicare, especially Part B at this time. And I'm happy to leave our direct phone number if that's okay.
Sure.
212-602-4180. Again, that's 212-602-4180. If you are a service provider and you need help, just identify yourself when you leave a message. We're all working remotely, so everyone's just leaving messages. And HICAP.
Great, thanks.
Thank you so much, Valerie. Thanks, Haley.
Thank you. Any other announcements? Okay. Any other questions? All right. You can always email us also at eflrp@nylag.org if you have any questions from the presentation. But I will email out a link to view it, probably on YouTube. We'll get that. We'll make that happen. All right. Well, thank you all for participating. And
sorry, I just want to make sure. There was a question that came in about FLIPS hours, so I did want to say we are still Doing intake, we are also all working remotely. Our intake is still open from 10 to 2 Mondays and Wednesdays, and the flirp@nylag.org email inbox is still open. We are answering all intakes through voicemail, so please do leave a voicemail and we will get back to you.
Want to give the number, Haley?
Yep, 212-613-7310.
Great.
And we'll send out an email
Okay.
about that. People do know we are still here and still taking intakes.
Great. Thank you. All right. So I hope everyone stays safe. Your loved ones, your clients. We know that a lot of people have not survived, unfortunately, this crisis and will not. And our clients are so vulnerable. So salute everyone for working with and helping them stay safe. And thanks for participating.
Thank you.
I'll close it now.
Thank you so much, Valerie.
Thank you.
Thank you.
All right. You're welcome. You're
Thank you.
welcome. Thank you. Oh, and the snacks were terrific.
Enjoy.
Okay. Bye-bye.
Bye all.
Bye.
Bye.
Be safe, everyone.